Good afternoon, everybody. Thank you very much for joining us for the RCSI Charter Day and the Faculty Sports and Exercise Medicine session that we're holding in parallel with a number of the other faculties. Delighted to be here today to chair this event. Unfortunately, the Dean, Dr. Philip Carolan, couldn't be with us, but I am the Vice Dean of the faculty and will be introducing the speakers to you. We have a great lineup of speakers today. We have some international speakers, Dr. Edward Leskowski from the USA. We have Dr. Natasha Jones from the UK, as well as Dr. Philip Carolan, who will be presenting in a pre-recorded session. But to start off, we have a lady that needs no introduction, Professor Moira O'Brien, the founding, if we could say, the founding mother of sports and exercise medicine in Ireland, and she is Professor Emeritus of Anatomy in Trinity College Dublin. She's also chairperson of the board of the Irish Osteoporosis Society and continues to work in osteoporosis medicine, and I'm delighted to have her pre-recorded session today on the history of sports and exercise medicine.
Chairman, ladies and gentlemen, I'm going to give you a brief talk on the history of sports and exercise medicine in Ireland. It is not the most vibrant of subjects, but is one that should be heard. In the 50s and 60s, most sports injuries were looked after by doctors who were also athletes involved in various sports, and they did this on a voluntary basis. They came from many different areas of medicine, including student health officers from both Northern Ireland and the Republic. There were very few federations that had their own honorary medical officers in the 70s. The exceptions were rugby, swimming, boxing, and horse racing. The GAA had doctors that played Gaelic games, but also attended matches, and they did this for the love of the sport. There were no physiotherapists involved. Sports medicine was much further advanced in the Scandinavian countries and in Great Britain, that it did not exist in Ireland in the early 70s. Mr. Bob O'Connell, a surgeon from St. Vincent's Hospital in Dublin, was the honorary medical officer for the Irish Rugby Football Union, the IRFU, and he organised the first international conference in Dublin to commemorate the centenary of the Irish Rugby Football Union in 1975. The International Rugby Medical Advisory Board was set up in 1977 as a result of the meetings that took place during that conference, and some Irish doctors have been represented on that board. BASM, the British Association of Sports and Exercise Medicine, held their first one-week course in Loughborough following the conference. I first became involved in sports medicine, looking after the students in the Royal College of Surgeons for gratis from 1960 to 1984. I particularly looked after those who were taking part in inter-varsity competitions, inter-year competitions, and in the Hospitals Cup, because these were the areas where most athletes got injured. I also did research with the students on the effects of circadian rhythm on sports performance. We were testing the male Norwegian students rowers at 6 a.m. at the Trinity boat house, which was meant to be open. The rowers were out of sight when suddenly the guards appeared and asked us what we were doing. When we replied we were doing a physiological experiment, they said, "We've called it many things, but never that before," but they let us off. I was appointed Honorary Medical Officer to the Irish Olympic team in September 1979, and I did all the medicals and tested 200 athletes on a monarch bicycle in Dr. Austin Darrag's unit in St. James's Hospital. We had an old monarch bicycle and we did the testing in a bathroom. The medical team was Ali Murphy, who was the first chartered physiotherapist who had done a sports medicine physiotherapy in Canada. Joe Doran, the master from the Irish Rugby Union, was also part of the team. We looked after the athletes, the management team, the press and the television personnel. There was no funding. Everyone volunteered their time. I first got involved in sports medicine when I was looking after the students in the Royal College of Surgeons from 1960s to 1984. I was particularly involved with the intervarsity, inter-year and hospital cup competitions where most injuries tend to occur. I also did research on circadian rhythm. The Irish Sports Medicine Association, the ISMA, was formed in 1981 and lasted till 2005. It was an all-Ireland association and it consisted of both doctors and physiotherapists. The ISMA held an annual conference, and the first conference, Per Enström from Sweden was the main speaker, and he took part in many of the follow-up conferences that took place. To encourage other doctors to be involved, myself and Eileen Murphy organised weekend courses in sports medicine for doctors and physiotherapists. We also organised a 10-week evening course in the Royal College of Surgeons, which consisted of clinical anatomy, the mechanism of injury, musculoskeletal examination, and taping of the common injuries and joints. FIMS, the Fédération Internationale de Médecine Sportive, is the national federation for sports medicine worldwide. The ISMA joined the Northwest European chapter of FIMS in 1981. The chapter met every year in a different country and held a conference and held social events. There was always a competition to see who could produce the best program for the social events. We won it on a few occasions. The annual conferences of the ISMA and Northwest chapter, when they held combined conferences, were in 1985, 1999, and the largest was in 2001 in Dublin. The conferences reported the latest research and was an opportunity for people to meet the leading international speakers. Many were awarded honorary fellowships by the faculty for their contributions to Irish sports medicine. In 1985, Bernard Dunn and I set up the Human Performance Lab in the Anatomy Department in Trinity College, which is unique in the world. Bernard has played a major role in the success of many Irish athletes at world, Olympic, international and national level in multiple disciplines, and has also helped recreational athletes to improve their performance. We set up a first osteoporosis DEXA unit in the lab and participated in clinical trials for osteoporotic medications. We also use this to monitor the athletes and members of the public. Bernard and I organised the first full-time MSc course in sports and exercise medicine in UK and Ireland in 1990. A research thesis was an essential component of this master's, and our external examiners were world-recognised experts in sports and exercise medicine. Bernard was the supervisor for many participants doing PhDs and MScs in sports and exercise medicine, and also in exercise physiology from 1985 to 2018. Bernard was recognised for his extensive contribution in 2014 by an honorary fellowship of the faculty. This is the lab in the 80s, a vast difference from the bathroom that we used in Austin Darrow's unit in James's for the Moscow Olympics. I was the medical director, and Bernard Dunn, Dr. Pat O'Neill, Professor Donald Macaulay, Eileen Murphy and Tom Giffney all lectured on the course from its beginning in 1990. There were many other people who also contributed by giving lectures. Pat O'Neill, a medical consultant and university lecturer in orthopaedic and sports medicine in Trinity, has played an essential role in the development of sports medicine in Ireland and in the MSc in Trinity to the present time. Dr. Mick Manny has also played an important role in the MSc since 1995, and from 2007 he's been Assistant Professor of Anatomy in Trinity and Medical Coordinator of the MSc course. Dr. Neil Fleming, who is an Assistant Professor of Anatomy in TCD, is also the Director of the Human Performance Lab since 2018, doing research and organising and teaching on the courses. Jim Tunney was the first Minister for Sport, and he set up COSPO, the Irish Sports Council, in 1982. He appointed me chairperson of the Irish Sports Injury Committee in 1982 to 1983. Our remit was to increase the participation in sport and to make recommendations to prevent injuries. Over 20 recommendations were made. Minister Tunney also set up a lottery for sport, but unfortunately the money was given to another department. The majority of sports previously were amateur, but this has changed, and there has been a marked increase in professional sports in the last decade, which has required much more monitoring and looking after of the athletes. Doping and corruption has unfortunately ruined many sports. The National College of Physical Education was founded in Thomond College in Limerick in 1971. In 1980, when the University of Limerick was formed, it became the Department of Physical Education and Sports Sciences. Dublin City University, DCU, the Department of Physical Sciences, was formed also in 1980. Education and research are two of the most important factors in the development of sports and exercise medicine. Unfortunately, physical exercise, PE, is only optional on the leaving certificate. More money should be invested in sports in schools, as the health of our young is directly affected, as the majority do not do the required 60 minutes of weight-bearing exercise daily. PE can help reduce the risk of multiple diseases such as osteoporosis, diabetes, obesity, depression, etc. The Sports Council was formed in 1999 and John Tracy was its first chairman. John was an Olympic silver medalist in Los Angeles, and he has only recently retired. Universities, technical colleges have increased the number of both undergraduate and postgraduate degrees in areas related to sport, exercise and disease. These include exercise physiology, physiotherapy, physical therapy, nutrition, pharmacology, psychology and IT, to include some of them. University research in these areas are taking place now, and sports scholarships are now available in many universities. In the 70s, researchers worked with colleagues in other universities and hospitals. Very little funding was available. We were doing a study with Pat Cottrell in Galway, and we had 2 months' worth of frozen saliva to measure salivary progesterone. It was in a bag in a car, which was broken into and stolen. They must have got quite a surprise when they discovered what it was. Research has changed since the 70s and 80s with the development of new technical advances. Increased funding and newer technology has resulted in major advances in the areas of sports and exercise medicine. Research done in Irish hospitals, universities, sports clinics and sports clubs have been published in peer-reviewed journals and presented at conferences, seminars, webinars, lectures and journal clubs, particularly during the COVID epidemic. The Faculty of Sports and Exercise Medicine in Ireland was formed in 2002, and the Foundation Fellowships were awarded in 2003. It's a multidisciplinary specialty, and it has taken a lot of very hard work by the faculty to try and get it recognised officially. I would like to thank all the health professionals who over the years have contributed to the development of sports and exercise medicine, and I would particularly like to thank the administrators of the faculty, Alban Purcell, Stephanie Below and Anne-Marie Crichton, for all the hard work that they have done over the years. One thing that has not changed is that in order to help an athlete or a patient, they need to trust you. And in order for that to happen, you must listen to them. Thank you very much.
Thank you very much, Professor O'Brien, and thank you for your inestimable contribution to the birth and growth of sports medicine in Ireland, and hopefully you will be able to join us at the end for the question and answer session. So speaking of that, we do have a live Q&A session when all our speakers have finished speaking, and so if you do have any questions, you can pop them in on the Charter Day website there, and to whoever you would like to address that question. So moving on, in a slight change to the order, Dr. Natasha Jones is going to present next. Dr. Jones is the president of the Faculty of Sports and Exercise Medicine in the UK. She is a consultant sports and exercise medicine specialist, and she works in the Oxford University Hospitals Trust, NHS, in the NHS, and she works in the Nuffield Orthopaedic Centre, where she sees complex musculoskeletal presentations as well as sports and exercise medicine. She's worked at the English Institute of Sport at Bisham Abbey, where she's worked with both Olympic and Paralympic athletes, and we're delighted to have her join us today to tell us about the state of sports and exercise medicine in the UK. Thank you, Dr. Jones.
Thank you. So I think my slides are going to be shared centrally, so we'll just wait for those to come up, I think. There we go. Lovely. Thank you. And thank you, Professor O'Brien, for your fantastic and really interesting history of sports and exercise medicine in Ireland. I found it fascinating. I'm going to really only talk about the last 15 years and mostly focus on our plans going forward in the UK. I hope that's okay by everybody. So we formed the Faculty of Sport and Exercise Medicine in the UK 15 years ago. I'm the 5th president and the first female president. We now have 712 members and fellows. We're a multidisciplinary faculty. Our members and fellows include GPs, obviously consultants, physiotherapists, podiatrists, and physical trainers. We have a number of different membership categories, from a fellowship for specialists who've completed specialist training or CSER, a membership for people who've completed our membership examination, both parts of it, and an associate membership for physical trainers mainly, and a diploma membership for people who have passed our diploma exams, which I'll talk to you about shortly. So in 15 years, there's been a huge amount of progress made. We now sit on the Academy of Medical Royal Colleges and so have influence at a national level. That has given us a huge amount of help and knowledge of the system and in the NHS, which is absolutely vital for our training and therefore for our specialty. Can we go on to the next slide, please? I'm just going to talk you through our strategy for 22 to 25, because I think by going through that, you'll probably understand where we're at the moment and what the plans are from the UK, which sort of probably gives you an idea of the challenges as well. Our overall mission or vision is to improve the health of the nation through physical activity. And that's a vision that can unite us all, whether we work through the inspiration of sport, whether we work in the prevention and treatment of disease through physical activity, or whether we work in the knowledge that musculoskeletal medicine is a determinant of physical activity. So it is a vision that can unite us all, whoever we are, and wherever we work within our very diverse specialty. Our mission has changed recently in our new strategy, and it has changed to developing a strong unified voice for sport and exercise medicine community. We think this is increasingly important as we try to increase our influence at a national level. And in order to develop a unified voice, we need to be inclusive to doctors of all specialties, as well as multidisciplinary members. So our values for the next 3 years are to grow the specialty, to unite the specialty, and to support those within our faculty. And I'll just talk to you about how we're planning to do that. And we have 3 main objectives. So if we could just go on to the next slide, please. So our first objective is to demonstrate and develop the value of exercise and musculoskeletal medicine in the NHS, because without that, without an NHS place, our specialist training will struggle and may cease to be funded. And so to us, the understanding of where SEM consultants sit within the NHS, both in musculoskeletal medicine and in exercise medicine, is absolutely key. So how are we going to do that? Well, we're going to work with, we are already working with national partners to develop collaborative models for integrated care systems, which is a new way that health is now delivered through the NHS. Those national partners include people like the Chartered Society of Physiotherapists, the OHID, who are the office, who are a government body replacing Public Health England, through partnerships with important people like BASM, who Moira already talked about, and other organisations, smaller organisations like the Primary Care Society of Musculoskeletal Medicine and others, all of whom have an interest in this agenda, all of whom work very hard on this agenda, and all of whom we'd like to be involved with. As I said earlier, we have national influence through the Academy of Medical Royal Colleges, and importantly through our parent colleges, the Royal College of Physicians of London and the Royal College of Surgeons of Edinburgh, both of whom provide enormous knowledge, support and expertise to our faculty, to our executive and to me, and I'm massively grateful for that. So how are we going to do that? Well, if we go down to the bottom of that slide, we need to define the role of sport and exercise medicine within a multidisciplinary care pathway. And that's it's a fairly general thing to say, but I think it's really important because the role of an FSEM consultant isn't just about delivery of care to patients. It's about providing governance across the multidisciplinary team and about particularly education throughout the multidisciplinary team. And our role, particularly in exercise medicine, is really evolving in those areas rather than through direct patient care. And I think that's a really interesting way that we can deliver care going forward and how we can be really useful to the NHS. We then need to demonstrate the impact of that, and we can do that through various data that we can collect through our musculoskeletal care pathways, but also through analytics data and other data that we can gather through our Moving Medicine initiative, which is our physical activity initiative. Moving Medicine, you may or may not have heard of, is our really big piece of work on physical activity, and it's our first really big piece of work on physical activity. I'm just going to ask you to see if you could you just go across to the website I sent you earlier so we can just have a little look at that together. I don't know if that's possible. So if you just go to the next I think this might work. We'll see how it goes. Okay, so you're viewing the Moving Medicine website at the moment, just in case you haven't already seen it. Can I just get you to play that video for you? Just press on the video there. I hope you can hear this. Thank you. If you could just pop back to the website itself now. So, yeah, while we just find that, I think, yes, thank you for that. If you just stay there, I'll just tell you where to look in a minute. So this is what I was talking about when I was talking really about our role as consultants and as a faculty in education, because of course we can't deliver physical activity or musculoskeletal medicine to the UK on our own. We need to do that through the massive workforce which is out there. Physical activity needs to be delivered by everybody who works in the NHS, and for a lot of people who don't work in the NHS. And so our role needs to be to drive standards, educate, and come up with innovative ways of delivering this message to the workforce. And music medicine is an example of that. This is a resource that's been produced by over 900 health care professionals to date, and many patients in its formation. And essentially, it is a way whereby we can support healthcare professionals to deliver physical activity interventions in practice, and importantly, in a way that is likely to promote behavioural change. Can I just get you to click on Consultation Guides at the top of that page, please? Thank you. So we have already quite a few resources there for both adults, children and adolescents, and there are more about to come, including menopause, type 1 diabetes, anxiety and depression. These have been produced by specialists in each of those areas, by FSEM consultants and by a wider multidisciplinary team with a lot of patient input. These were essentially produced through funding from Public Health England and now OHID, originally from Sport England, as part of their wider programme called Moving Health Professionals Forward. And I'll just get you to move on to active hospitals, if you just could click on that as well, please. We've also produced, again, a toolkit essentially for people who want to improve physical activity in hospital systems, and this takes you through the long-term plan and how it can fit into the long-term plan. It takes you into how to design and deliver pathways across hospital systems. So, for example, pre-operative pathways, acute medical pathways, maternity pathways, and these are continually being built through work that's being done across the UK now. And there's also a lot of advice there about how to provide governance to those pathways. And could I just go on to supporting you, please? And to online course. Just below that, that's it, thank you. So our online course is essentially a motivational interviewing course, which is applied to physical activity. It's been extremely well received, and we've had at least 400 people through this course to date. And essentially it teaches healthcare professionals how to talk to patients about physical activity in a way that's likely to impact on their behaviour, which is really key to everything that we do. So that's a sort of a whistle-stop tour of moving medicine. There's quite a lot more coming to do with what we call a place-based approach. So making this website more bespoke to certain areas of the UK. We're just about to do one for Birmingham, for example, to support their Commonwealth Games campaign. We also have some international sites, one in Australia, one in Northern Ireland, one in Scotland, and we're looking to develop more. And we work with partners across the globe, including Exercises Medicine and ACSM in the US. And so if we could just go back to my slides, please. Also, we're just about to launch a diploma in exercise medicine, which again will give you diploma membership of the Faculty of Sport and Exercise Medicine in the UK, and is an online exam. So just go to the next slide, please, and the next slide. So our second objective, so coming away from exercise medicine and the NHS a bit, is about elite sport. Many of our members and fellows work in elite sport, and indeed it's one of the great attractions to our specialty, I think. Some people work only in elite sport, but most people have a portfolio career, so work in the NHS, a bit of private practice perhaps, and elite sport. It's an incredibly inspirational environment to work, and as I said, it's extremely attractive. But with it brings a lot of risk, and the more consultants we train and the more they work within elite sport, the greater that risk is. And the risk really is about doctors working in very high pressure but very isolated environments. So we've been doing quite a lot of work recently, looking back over the learning of the last 15 years to try and understand how our processes can best support those doctors working in those environments. We already have an appraisal and a revalidation system, which we're reviewing at the moment, but we'd like to do more to do with perhaps some mentoring, perhaps producing some educational materials in collaboration with BASM. One of the biggest challenges, I think, of working in elite sport is the providing robust governance in the sort of environments which one finds oneself, often consulting in corridors, etc., often with lots of external pressures affecting the relationship between you and your patient. So one of the things I think would be really useful to do would be to develop a diploma in governance and ethics in elite sport, and to make that a mandatory requirement for appraisal and revalidation if that's done through the faculty. And I think that would continue to drive up standards in elite sport, and it's something we'll be working towards in the next 3 years. We're also working to develop accreditation for GPs with a special interest in team sport and elite sport. Many of the doctors working on the touchline in team sport are GPs, and again, many of them aren't members of our faculty at the moment, and again it's a very high risk environment. So we're going to be producing a diploma that they can take and then can apply for diploma membership, that they can then go on to our mentoring appraisal programs. So this is a process that we've set up over the last 6 months. We've got an external review at the moment, which is being delivered by extremely well thought of professional review company who've had a lot of experience working across medical royal colleges. So I'm hoping that the outcomes from that will help us change our practice and bring us in line with the best practice in the UK and elsewhere. And if we could just go to the next slide, please. And our third big objective is to develop FSEM as a collaborative multidisciplinary organisation capable of uniting the specialty and delivering our goals. And this is really about looking internally about what we do rather than looking externally. One of the problems that we have come across now that we're 15 years old is the gap in leadership skills. So we have many senior members and fellows who have driven this through the last 15 years incredibly successfully and with a huge amount of hard work. We also have lots of fairly junior consultants, many of whom have only been consultants for 5 years or less. And we need to support them to develop the leadership skills that they'll need in order to drive our specialty forwards once I'm retired and many of my colleagues are also retired. So we have set up a leadership course, again in collaboration with BASM, which we'll be recruiting to in the next 2 or 3 months, and it'll be a 2-year leadership course with mentoring, which will be delivered by us in collaboration with the Royal College of Physicians, who of course have a huge amount of experience in delivering leadership training. We will also be developing an enhanced mentorship programme, which provides meaningful mentorship to our particularly younger consultants, but all the way through their careers. Mentorship is sort of a bit of a hot potato, really. It's really difficult to deliver effectively and really difficult to resource, but we're looking at ways of doing that, because we consider that essential as a sort of alongside to the appraisal and revalidation process. The third thing we're doing at the moment is we're establishing ourselves as an independent charity. Currently we sit within the auspices of the Royal College of Surgeons of Edinburgh, and although they remain as one of our parent colleges, we'll be financially independent from them, and also our governance will be independent from them. That will give us a lot more flexibility in the way we recruit our team, support our team, and financial flexibility as well. It's a small move, but it's a significant move. And again, we're very grateful to the Royal College of Surgeons of Edinburgh for looking after us so well for the last 15 years. But we feel now's the time to start to develop some legs of our own, and they're very supportive in that. The fourth thing is this very exciting consultation process we have going on with BASM, who are our associate or are the British Association of Sport and Exercise Medicine, and have been around for a lot longer than us. They've been around for over 50 years now. We have fantastic relationships with the executive team at BASM, which we've been developing over the last 15 years, and we continue to develop. But the conversation we're having at the moment is whether or not we'd be better dissolving both organisations and reforming as a single organisation with an aspiration eventually to become Royal College of Sport and Exercise Medicine. That's going to be a long journey to get to that. There's a lot of things that need to be considered to get to that, but the first stage of that process is underway, and that's the consultation between BASM and us, which will be going over the course of this year, in order to really work out what that would actually look like in terms of membership and fellowship structure and so on. As I said, that's an ongoing process, and once it's complete, a report will be produced, and then our members and fellows and BASM's members will be able to vote on whether they want to take that forward. I think it's really important that this consultation happens at this stage, and I very much hope that we can come to a conclusion which is beneficial for both organisations in the long term. I don't want to preempt that conclusion today, but I think both organisations would really appreciate clarity going forward, whether it's together or as organisations which work alongside each other. And the last thing we're doing, and I saved it for last, but it's one of the most important things I think that we're doing, is we're really trying to up our game on the equality, diversity and inclusion agenda. Sports medicine in particular traditionally attracts men, white men, and we have quite a lot of figures to say that we're no different to anybody else on that. So we're setting up a committee in collaboration again with BASM to try and work out how we can best support women in sport and exercise medicine, but also a much more diverse approach, which I think will help us not only deliver our services to athletes, but also will improve our impact in the NHS, particularly on the health disparity agenda, which is hugely important and key in the long-term plan. And the next slide, please. So I think that's about me. I want to thank you very much for listening today. Unfortunately, I'm unable to join the panel session at the end of the day, but if you send any questions, I'm sure they can be forwarded on to me, and I'm more than happy to answer them. And thank you very much for inviting me to come and present to you today. I hope that's been interesting.
Thanks very much, Dr. Jones. That was great to have you, and thank you for giving up a little bit of your afternoon to come and speak to us. I just had a quick question, something that I've just noticed in the sort of the naming, particularly in the UK, and we haven't taken it on board here yet, but it seems to be sports, exercise, and musculoskeletal medicine now. Was that decided, or was it just something that evolved, or just a better way of describing what we do?
We are still the Faculty of Sport and Exercise Medicine. We have been toying with the idea of changing our name for the last few years, and have put it off really until we have a decision on whether or not we're going to be merging with BASM or reforming as a new organisation with BASM. Because if we did that, that would be an ideal time to change our name. But we will be inserting musculoskeletal medicine into our title, because one of the problems that we do consistently have is a lack of understanding about what we do in terms of musculoskeletal medicine in the NHS. And that's partly driven by the title, I'm afraid. So, yeah, we're working on that.
Perfect. Thanks a million. So we'll leave you go, and hopefully we can get you back to talk another time as well. Thanks a million for your talk.
Thanks.
So moving on, we have a pre-recorded speech from Dr. Philip Carolan, who again needs no introduction. He is the current dean of our faculty and has served in every position of the officers of the faculty. He is a consultant sports and exercise medicine physician in the Sports Surgery Clinic in Dublin. He is also the cabin GAA team doctor, and has a particular interest in groin and tendinopathy. He was unable to be with us today, but he has left a talk for us.
Good afternoon, ladies and gentlemen. It gives me great pleasure to present in this parallel session 3 of the Charter Week programme on behalf of the Faculty of Sports and Exercise Medicine. I would like to thank Professor Ronan O'Connell, President of the Royal College of Surgeons in Ireland, and the Charter Week Organising Committee for inviting the faculty to host a parallel session. My name is Dr. Philip Carolan. I'm the Dean of the Sports and Exercise Medicine of the Royal College of Physicians of Ireland and the Royal College of Surgeons in Ireland, and I've been asked today to speak on the current status of sports and exercise medicine in Ireland. I know Professor Moira O'Brien has outlined the history of sports and exercise medicine, but I'd like to highlight in May 2004, the Faculty of Sports and Exercise Medicine was recognised and accredited as the training body for the specialty by the Medical Council and the Department of Health and Children in Ireland. Our training is governed by the Training Committee of the Faculty, and this committee reports back to the Faculty Board. We are the officially recognised postgraduate training body for sports and exercise medicine in the Republic of Ireland, and it is recognised for this purpose by the Medical Council and the Health Service Executive in Ireland. The Training Committee is the advisory body to the Faculty of Sports and Exercise Medicine for all matters in relation to higher specialist training, and makes recommendations for the award of the Certificate of Completion of Specialist Training, CCST. As I've stated, we were officially recognised by the Medical Council and the Department of Health and Children as the recognised training body for sports and exercise medicine, but our training programme officially went through the accreditation process of the Irish Medical Council on the 2nd of December 2015, and we received outcome notice of our approval with conditions for our training programme on the 14th of December 2016, a whole year after the faculty went through the accreditation process with the Medical Council. And we officially got notification of our accreditation of our training programme by the Medical Council in March 2017, and subsequent approval by the Department of Health in May 2017. At that time, we had to go to the HSE NDTP to secure funding for our trainees to go through the specialties as outlined and approved by our training programme. So our first intake of trainees was in July 2019, and I'm happy to say that our first 2 trainees completed our training programme in July and October of 2021. Our training programme is a 2-year programme, and it's open to all applicants who have a CCST in a primary specialty, and this would include all specialties recognised by the Medical Council of Ireland. They also require an MSc in Sports and Exercise Medicine to apply for the training programme. In year one, they do 6 months in A&E department at St Vincent's Hospital and 3 months in both the National Rehabilitation Hospital and cardiology in Tallaght University Hospital. In year two, they do 6 months in Cap Orthopaedic Hospital and 6 months in the Sports Surgery Clinic before receiving their CCST in Sports and Exercise Medicine. As stated, we have a 2-year programme up and running, and we presently have 3 trainees going through our training programme at the minute. We have completed the cycle of 5 years as of 2021, and the faculty went through the reaccreditation process of its training programme with the Medical Council on the 6th of December 2021. During the year of 2021, the faculty were notified by the Medical Council that we weren't in compliance with Article 25 of the EU Directive with regard to medical training. And we had a number of meetings with the Medical Council in regard to our training programme and their generalised outline of where and what they felt we needed to do to comply with the EU Directive. So we've gone through the reaccreditation process of our 2-year programme as of the 6th of December 2021. And as of today, we still have received no notification from the Medical Council with regard to our training programme. However, we have been reassured by the CEO that we can continue with recruiting trainees, and we've notified our recent applicant that he will be starting training in July 2022. We have had long discussions with the Medical Council, and it stated that we were felt to be a super specialty in that we required all our trainees to have a CCST in a primary specialty and also an MSc to enter our training programme, and that this wasn't in compliance with the EU Directive. They've recommended that we would put together a 4-year programme that would allow trainees join from basic specialist training. At the minute, our programme director and his assistant director, Dr. Jim O'Donovan and Dr. Brian Whelan, are looking at the curriculum for a 4-year programme, and we are in close discussions with the HSE NDTP to secure funding for trainees in a 4-year programme, as it would need to incorporate a number of other specialties for further rotations to encompass all areas of the curriculum of specialist training in sports and exercise medicine. Of course, at present, there are no public funding consultancy posts in sports and exercise medicine in Ireland, and we are also in discussion with the HSE and the NDTP to look at developing public funded consultancy posts, and this would be in line with the Sláinte Care model, as we feel that our specialty incorporates musculoskeletal medicine, exercise medicine and lifestyle medicine, which would be very beneficial for the welfare and health of the Irish population going forward. We are, as I said, awaiting approval of our 2-year programme from the Medical Council with an outline of putting together our 4-year programme over the next 5 years. We continue to have the challenge of only having privately funded consultancy posts, but we are in discussions with the HSE NDTP to figure out a process of coming up with a publicly funded consultancy post in our public hospitals. So our major challenges at the minute are putting together a 4-year programme, securing funding for a 4-year programme, and also getting publicly funded consultancy posts in our public hospitals. We continue to run our 2-year programme, and we envisage that when we put together the 4-year programme that we will have the option of having a 2-year programme for candidates who wish to complete a CCST in a primary specialty and then go on and do sports and exercise medicine as a secondary specialty, along with accepting candidates from basic specialist training to do a 4-year programme. I hope this is a brief outline of where we are at the minute with regard to sports and exercise medicine training in Ireland and where the specialty is within the current health model. I would be hopeful that over the next number of years that we would be able to secure some publicly funded consultancy posts which will help develop the specialty going forward. I apologise that I'm not unable to take questions and answers today, as unfortunately I'm away on holidays, which has been booked prior to the removal of the Charter Day date, when it was decided that they could have some in-person meetings. Again, I'd like to thank the Royal College of Surgeons Charter Week Committee for inviting the faculty to run a parallel session. And I'd like to thank the President for all his support to the faculty over his term as President. I'd also like to thank my co-speakers for giving us their time today to do presentations with regard to the specialty of sports and exercise medicine. If anyone has any queries or any questions for me, I'm more than happy to deal with them if you circulate them to the faculty office by email, and I'll get back to you on my return from holidays. Thank you.
Thank you very much, Philip, for that quick update on what's going on with the faculty in Ireland. Moving on then to our last speaker of the day, we do have Dr. Edward Leskowski. He is a specialist in physical medicine rehabilitation with an additional subspecialty in sports medicine. He is the former co-director of the Mayo Clinic Sports Medicine Department and professor in the Department of Physical Medicine Rehabilitation and the Division of Sports Medicine, the Department of Orthopedics at the Mayo Clinic in Rochester, Minnesota. He is also a fellow of the American College of Sports Medicine, and we are delighted. He is also a fellow of the Faculty of Sports and Exercise Medicine in Ireland. And Dr. Leskowski is going to speak about how sports and exercise medicine is doing in the US, or particularly in relation to physical medicine rehabilitation, which is his specialty, but sports medicine in general. Thanks very much, Dr. Leskowski, for joining us today.
Thanks so much, Suzi. It's my honor to be here, and I'm actually at a meeting in Barcelona, so it's nice to be able to plug into this, and really neat to hear all the speakers today. It's so interesting how there's so many parallels between how sports medicine developed, you know, in other areas, and also how it's developed in the United States. So I think we'll find a lot of similarities in some of the things that we discussed today. So, as you said, the title is The History and Evolution of Sports Medicine in my specialty, which is physical medicine and rehabilitation, but also tying that into how it's developed in general throughout the United States. And hopefully we can tie both of those together. My specialty had a lot to do with some of the early origins of sports medicine in the United States. Okay, just trying to. So for disclosures, I don't have any financial relationships or off-label usage. And I'd really like to say that just many people that I just won't mention in this talk contributed to the development of sports medicine in general. And I'm not omitting anyone intentionally, but trying to give a capsule summary here of this very large field. So we're going to talk about the role and evolution of the specialty of physical medicine and rehab with respect to sports medicine and the major people responsible for its growth throughout the years. And also a timeline for the major events which helped to establish sports medicine as a specialty, both in our specialty and how other specialties in the United States developed their sports medicine as well. This gentleman here is known as the father of my specialty of physical medicine and rehab. He helped establish physical medicine as a specialty in the American Board of Medical Specialties. And again, from the title, physical medicine and rehabilitation, a lot of early emphasis was on physical agents, heat, ice, modalities, electricity. That was a key component of the specialty early on. He was an early advocate of the use of physical therapy to treat injured athletes. And you can see a contrast bath there, big hot and cold there. In 1928, he established the Department of Physical Medicine and Rehabilitation at Temple. And he actually was the first person in my specialty, a physiatrist, to practice sports medicine. And he was appointed the team physician for Temple University football. At that time, there really wasn't a sports medicine physician in the States that cared for a university team. Before this, other providers cared for injured athletes, mostly in the equivalent of athletic trainers, which at that time was not as much developed as it is now. Frank Cruzen was appointed chairman of the Physical Therapy School at Mayo Clinic in Rochester and the AMA's Council on Physical Therapy, the American Medical Association. He collaborated with John Coulter at Northwestern, who established the program at Northwestern University in Chicago. That was my medical school. And Coulter was an Army physician, and a lot of the military injuries really related to a lot of what we began to do with sports medicine and sports injuries. So Coulter promoted, again, use of modalities for pain control, physical therapy, exercise in the treatment of disease and injury. We'll mention women here. Frances Hellebrand was a key woman physiatrist and physiologist in the 1930s and 40s, and she did a ton of research on muscle disorders, on exercise science, the value of physical education, and physical therapy. And she also was instrumental in establishing the specialty of physical medicine and rehabilitation at many institutions, as you see. She expanded the work of DeLorme Watkins, which you're likely all familiar with, on muscle overload and progressive resistance. And she collaborated with Peter Karpovich.
We've just lost you there, Dr. Leskowski. We're just having some technical difficulties. I think we've lost Dr. Leskowski. It's coming back in. We can't hear you there, Dr. Leskowski. You're on mute.
Okay, can you hear me now?
Now we can hear you. Yeah, we just need to share your slides again there.
Did everybody hear up to this point? Is that right? Did everybody hear up to this point? I hope.
Yes, we heard up until then.
Okay.
Thank you.
Okay, thank you. Just moving on here, in the 1940s and 50s, again, related to the war, Bernard Baruch was a philanthropist who recognized the need to serve our veterans and those who had served in the war and get them back to optimal functioning. So he formed a committee to really, in 1943, develop the specialty of physical medicine and rehabilitation. And again, one of the chairs of Columbia Medicine was on this committee, to the subcommittee, which again really focused on the importance of physical fitness and exercise physiology as the foundation of our specialty. There was a report at that time in the Journal of the American Medical Association that said that all physical examinations should include assessments of physical fitness and function. And at that time, it's been mentioned, the exercises medicine in the American College of Sports Medicine and your movement medicine. At that time, they recommended a prescription for specific training or exercise therapy. PM&R was recognized as a medical specialty in 1947, but a lot of people didn't understand what it was as a specialty. And, again, as late as 1966, after almost 20 years after it was established, you see this quote that really basic physicians, general medical physicians, didn't understand what we did in PM&R. There was a physician named Ernie Johnson at Ohio State, ensured that really we remained a strong musculoskeletal and physical medicine specialty, and did a lot of great research in those domains. I was part of the founding of what we call the Physiatric Association for Spine, Sports, and Occupational Rehab. This was in 1994, and I was one of the charter members with this gentleman, Jeff Saul. And this was designed to address musculoskeletal medicine and really provide a forum for growth of that area. And we actually affiliated with a journal called the Clinical Journal of Sports Medicine. And it rapidly grew in our specialty to over 1,000 members, and eventually was integrated into our American Academy of Physical Medicine and Rehabilitation as a musculoskeletal medicine council. In 1991, the American Medical Society for Sports Medicine was founded. And in 1999, you may have heard of CAQ, so that's Certificate of Added Qualification for those completing ACGME fellowships. At the time, these were family medicine, emergency medicine, internal medicine, and pediatrics. And in 2007, the American Board of PM&R granted subspecialty certification in sports medicine to PM&R residents. So really the pathways for sports medicine as a physician can be through family medicine, can be through internal medicine, can be through emergency medicine, pediatrics, or physical medicine and rehabilitation. We all take the same examination for the Certificate of Added Qualification in Sports Medicine. Currently, there's 19 specialty programs accredited by the American Council on Graduate Medical Education. There's sports medicine fellowships. Again, they have to establish a certain standard to be accredited. Just a little touch on one of the Olympics that I was involved in 2002, the Salt Lake City Olympics. They were the first major international competition since 9/11 in the United States. So we didn't know what was going to happen and if this would be a target event. It was in Salt Lake City, Utah, as you may remember. We had CDC staff on site monitoring disease counts, things like that. We had crucial to have extreme preparedness. And this was one of the first times the polyclinic became developed in the Olympic forums. We really developed a template for what really goes on now. We took care of, in addition to athletes, spectators and volunteers, and we handled all the medical issues, both general medical, musculoskeletal, and doping control. And we also had medical, dental components, optometry, and podiatry. All these services were free to the athletes. So the population served about 2,500 athletes, 2,500 coaches, officials, judges, and the workforce, including those volunteers. We had physicians on staff. We had 10 orthopedic physicians, 8 from physical medicine and rehabilitation, 1 rheumatologist. Those were all the 19 musculoskeletal physicians. And we did shifts. We developed this template that's still in use today. The visits during time opens is in 2009, that's 2002. So it's 39% of the athletes. There were a lot of other people other than athletes that we saw as well, including volunteers. You can see how the visits changed from Nagano, which was before 1347. So 2,098 visits was almost a doubling from 1998. And it went on, you can see the huge increase there in Sydney. So we kind of had the template for future Olympic polyclinics, how they would be staffed, how they would be handled, the triage criteria, and the flow. So we had multidisciplinary care, and we integrated the practice to provide the right care for the right patient. And this has continued until today. Where are we headed? Well, you know, a lot of musculoskeletal ultrasound in Europe, and I know you all have used it forever. We are really beginning to become pioneers in the advancement, in the States at least, of musculoskeletal ultrasound, our specialty. So all the advantages that we know of, the resolution, the ability to do dynamic evaluations of ligaments, say the ulnar collateral ligament in a baseball pitcher. We can perform ultrasound-guided procedures, and we're working on microsurgical techniques for even things like compartment syndrome, adductor tendon releases. This is even more microsurgery than an arthroscopy. So this is just an incredible field that is just exploding with literature, with research, and with practical interventions, of course, the delivery of orthobiologics as well. And orthobiologics, I don't like to use the term regenerative medicine. We don't regenerate, but we do harness the body's healing capabilities, stem cells, growth factors, you all are familiar with. We need to validate this. We need to have evidence-based medicine to support it. There's a lot of stuff being injected into a lot of people that we haven't validated yet. So it's going to be very important to make sure that you know, we have evidence-based research to support its use. But certainly for musculoskeletal injuries, tendon, muscle, ligament. It's being incredibly explored. And as was said, the health, exercise is medicine, motion is lotion, movement is medicine. I had the privilege of serving on 2 presidents' councils under President George Bush and Barack Obama. I also worked with President Clinton, who is a big advocate with the Robert Wood Foundation on establishing greater public fitness in the United States. We have a world epidemic, as you all know. 70% of the world is overweight, obese, sedentary lifestyle. I've given lectures in China and Dubai, everywhere. It's the elephant in the room that is contributing to a lot of disease burden, both cardiovascular and musculoskeletal, and in many other ways, endocrine, type 2 diabetes, as you can imagine. So part of our role is to get the word out on how much of a problem this is. And even now, we don't seem to be talking about it as much as we probably should be. And I had the privilege of George Bush was an amazing athlete. He scored in the top 0.5% of his age group in the Cooper fitness test. And he took me mountain biking through the woods with Secret Service in Virginia there one time, which was absolutely crazy. But we really, our focus on the committee at that time was really getting the word out on how bad things were. And a lot of lectures I gave, people used to come up to me afterward and say, Doc, I knew it was bad. I did not know it's this bad. And it is this bad, as we all know. Injury prevention is one huge area too. We're doing a lot of research and movement analysis. It's not practice that makes perfect, as you all know, it's perfect practice. So ensuring perfect practice with movement patterns to prevent injury. Anterior cruciate ligaments, as you all know, huge amount of injuries and dollars spent on treating them. We know there are definite risk factors, dynamic medial knee valgus with a single leg squat, hugely predictive of later risk of ACL injury. So and again, can we prevent? Maybe not, but can we protect? Probably. We can protect people from injury as good as possible with analyzing all the things that go into to contribute to an injury. So that's about it. We established sports medicine at Mayo Clinic in 1990 as an integrated practice. So we have in our group, we have orthopedics and physical medicine rehab. We call co-direct our center. We also have pediatricians. We have emergency medicine physicians. We have family medicine physicians, all on our staff. So it's an integrated practice. Again, it gets the right provider to the right patient who needs that provider. And we've had the privilege of being affiliated with a lot of professional sports teams in the United States, both United States Olympic Committee related and also professional sport related. But we always like to say that anyone is welcome in our center. We want to just improve the fitness and health of everyone. And the stuff we learn, as we all know, in high-level athletes, we can use that to translate to everybody. It's the same principles that are applied. So I just really thank you for inviting me. I'm honored to present with this truly esteemed group, and happy to have a few minutes afterwards. If anybody has any questions, happy to answer them. Also, you're certainly welcome to contact me via email as well. Thank you so much.
Thank you very much, Dr. Leskowski, for taking time while you're in Barcelona to speak to us today. We'll just see if Professor O'Brien is available there and see if the sound is working. Just see if she can come in there. While we're waiting there, Dr. Leskowski, would you have any advice for us here in Ireland to say, as Philip mentioned there in his talk, how do we convince our government that the need for SEM specialists, particularly exercise medicine specialists in our public system, to really promote that for our general population and our patient population?
It's a great question, Suzi, and I don't know that there's one single way, but it's in the United States at least, it's the most common. This always shocks everybody. It's the most common patient presentation to a physician is a musculoskeletal injury. The most common, as we all know, about 80% of people before the age of 50 have some kind of back pain, and we joke in sports medicine, we see everybody from the board of governors to the janitors. Everybody has some kind of musculoskeletal injury. So the magnitude of the problem is huge. And we even struggled with this even in curriculum for our medical students. I was part of the American Council on Medical Education's curriculum development committee, because we don't teach medical students that much musculoskeletal as we should. It's so common, and we kind of, it's an important system, but we kind of tend to, oh yeah, you know, it's not going to be life-threatening, so we maybe not emphasize it that much. And we even developed shelf exams for musculoskeletal, because we tested our residents and medical students as they came out of training and found the knowledge to be very poor. So it's kind of presenting that data to the powers that be, and you know, kind of working in that regard to establish things where hey, we can get it more. Now in our program, we have a musculoskeletal, you have to pass a musculoskeletal proficiency exam. So you have to examine a shoulder, examine a knee. You have to know what the major components are. And to graduate, you have to pass, and we test you and have a practical exam. So, you know, we're trying. I think it's hard, but the more we can kind of, the data speaks for itself, and the disease burden, again, as we talked about with obesity, a lot of the effects of obesity on the musculoskeletal system. The incidence of arthritis just skyrockets with percentage pound increase over ideal body weight, as we know. So, you know, we're seeing a lot of the effect, and people want the quick fix. You know, I joke, one of my colleagues is one of the world's experts in orthobiologics and regenerative medicine, and I tell him, if you take the best study in that area compared with the effect size of the best study on exercise, the exercise is 800 times more powerful. Mm-hmm. But we don't, you know, emphasize that. And that's the push again for exercise. It should be a vital sign. Every patient that checks in, we should say, how much activity are you getting? You know, even sleep, recovery, how much sleep? Those are key vital signs that aren't really emphasized that much. So, you know, through all the venues that you all are pushing as well, and I know you all are affiliated as well with the American College of Sports Medicine, we just keep trying to do those things and make the awareness such that people will take action.
Absolutely, and where lifestyle medicine, I think just all those components come in and really should be part of every curriculum in medical school. And I know probably the US are a little bit ahead of us in that regard as well. I'll just see if Professor O'Brien can hear us. No sound from Professor O'Brien. We can't hear there. And Dr. Leskowski, if you could say, you mentioned it there as regards musculoskeletal ultrasound and orthobiologics, where do you see sports and exercise medicine going in the next sort of 10 to 15 years in the US?
You know, I think even more minimally invasive. So the ultrasound is just an incredible tool, and we're using it now for, like we said, for fasciotomies, for compartment syndrome, for adductor tendon releases, to flexor pulley, for carpal tunnel releases. There's so many things, and those, you know, those cost a lot of money if you have an OR time and all, but if we can do a threaded carpal tunnel release in 10 minutes in the office and have same or better outcomes and less morbidity, that's powerful. So I think a lot of those, a lot of the musculoskeletal related ultrasound guided procedures are going to become more popular. I think the role of ultrasound even more so. We're using it in sideline diagnosis now. So coverage of sports events, you know, bringing the ultrasound out on the field as an aid in diagnoses. The machinery, as you know, is getting so much more advanced and compact and portable, and the resolution better all the time. And the real-time analysis that we can do with that is just tremendous. So I think that area is going to grow tremendously. But then also, and I tell our residents, the foundational principles are just so key. Exercise is medicine. And if we don't talk to our patients, we tend to, I think that technology sometimes can get us blinded almost, or we kind of go right to the ultrasound, we go right to the MRI. No, there are foundational things here. You know, you have a patient with a BMI of 48, we got to do something about that. So I think, yes, we have these great things. They're wonderful. They're great tools, but we also have to keep pummeling the foundational principles of how to, like you said, lifestyle medicine. How do we stay well throughout life, and how do we do these basic things in life to contribute to make us feel our best and be our best person?
Absolutely. And if I could ask you then, what would be your favorite memory from all your years in sports medicine throughout your career? Is there one that stands out?
Wow, that is a great question. A lot of it, when the Olympics I was talking about, I never even knew this, but that the care was free and all, and it was amazing. I think sometimes, again, for countries that are privileged to send their teams fully supplied and staffed, but I was seeing patients from countries who they had pain for 6 weeks, did not even get an X-ray, had a foot fracture they were competing on, it's dental issues they had never gotten addressed, musculoskeletal injury. So, it was really a blessing to be able to intervene like that and really give them care that they hadn't gotten before and give them a template for the future. So that was really cool. And I'm trying to do this now, not just sports, but do a lot of other areas that don't have as much knowledge about musculoskeletal medicine, as we said. And there's so many of those, and people are told they're shuttled off and, oh, you're done. And no, you're not done. We can do something about this. We can fix this. We can make it better. And, disabled athletes as well. I've worked a lot with on the U.S. Olympic Committee with the Paralympic Committee with disabled athletes. And that was one of my early passions in developing research there. And, it's just amazing to see these individuals. And they are truly athletes. They're not just, oh, look, he's doing that. One of my friends has done over 110 marathons in his wheelchair. And the guy has elite level times. These are great stories, and I think they're very inspirational to people as well. And again, the value of motion. Even if you have a condition or a disability, motion is going to improve that. And for the disabled, man, you see the amputee skiers come down the hill at 80 miles an hour, and in total control, and it's impressive.
Absolutely. And you are totally in the hot seat today because I have nobody else to ask questions to at the moment. But we do have one question.
Oh, I think you're muted. Somehow it got muted, Suzi. Now you're.
There we go. Professor O'Brien might be trying to come in there still. Let us know if you come in there, Professor O'Brien, if we can hear you. So we do have a question, and if anybody else has a question, we just have a few minutes left.
Hello, Suzi.
Oh, hello, Professor O'Brien. Thank you for joining us, and thank you very much for your talk earlier. Can you hear us there? Yep. Can you hear us? Can you hear us, Professor O'Brien? Hello? We heard you there. Still can't hear us. So we'll see if we can get the sound sorted there. But Dr. Leskowski, we did have a question come in, and I suppose it just can potentially open a very large Pandora's box. But what can be done to prevent concussion in the NFL? Is there any more of these head injuries we're seeing in sports like the NFL or rugby or anything like that?
Well, it's a great question, and we want to keep all our players, no matter what they play, as safe as possible. So, I think a couple of things that have really made a difference in the United States, at least, is rules. When we reduced the incidence of when we made spearing a penalty in football, the incidence of cervical spine injury plummeted, and the catastrophic injury really plummeted. So, and in hockey too, when you checking from behind, when that rule change came, the incidence of concussion and head injury plummeted. So I think looking at some things that go into why concussions occur in sport, and now we've had policy changes in the National Football League about head hits to the quarterback, vulnerable hits. You don't do that, so coaching to prevent that. You can be an incredibly skilled football player and that, take someone out like that. So I think rule changes, everybody has to buy into them, teams as well as coaches, as well as players. The equipment is another side. And with, as you all know, the complex forces required in concussion, the rotational forces, it's really hard to mitigate all of those. But I think we can mitigate some of them. And some of the new concussion helmets that are out now are when we do double-blind studies, they're doing better. They're doing better than the regular helmets. So as we develop the technology and there's airbags, things like that being tested now as well. That's part of it as well. So, and then conditioning, and teaching the player, see what you hit. Don't put your head down. Those types of how to fall appropriately in some of the sports, how to, get yourself out of trouble. Those are huge as well. So. but contact sports, I think, are always going to have that risk. We can try and mitigate it as much as possible, but and I think with the technology end, with the rule change end, and then the athlete education end, those are the three things we stress the most.
Absolutely, and unfortunately, even for everything that you do mitigate for, there can be very, very unfortunate accidents, as we had
Yes.
a case this week. And a 20-year-old girl, Kate Moran, was playing camogie, which is one of our national sports, and she was wearing a helmet and was hit with a hurl and unfortunately died this week. So extremely sad. But that's unfortunately that these things do happen. And we'll just see if Professor Moira O'Brien is there. Professor, can you hear us? One last time. So I think we're coming to the close of our session here in the Charter Day. I was hoping to get the opportunity to speak to Professor O'Brien, as she was certainly instrumental in my becoming a sports medicine doctor. I did the master's in Trinity in 2005, and certainly her breadth of knowledge and her experience is absolutely stunning to behold, and just to even learn for 1 year from her was an absolute privilege. And she gave me 2 bits of advice, which I have to say I very much held on to. I came straight out of sort of medical school, did my internship, and was going straight into sports medicine. But she said, no, go get your exams first, go get your membership of the college. And so I went about and did that, and then went into the master's. But the other thing that has always stuck with me, and I don't know, Dr. Leskowski, if you'd agree with this, but she said, as a team doctor, you should be seen and not heard. And that was what she told me. And I think it was just very, very good advice as a sports medicine doctor, just to always be there and to be available in the background, and knowing, and as she said at the end of her talk today, just so that people can trust you and know that you're listening to them.
I agree, Dr. Clarke. Very, very wise words.
Perfect. Thank you. So sorry we couldn't hear from you today, Professor O'Brien, but hopefully we'll get you back on. And similarly, Dr. Leskowski, we will hopefully hear from you again in the future. I know you do talks for our trainees in sports medicine as well, and we're very grateful for that. I hope you enjoy the rest of your trip in Barcelona. And thank you very much to everybody joining us today. If you do have any questions for the faculty, Anne-Marie and Stephanie are in the office to answer any of those questions, and we'd be delighted to answer them at any stage. Thanks very much, and have a great weekend.